Hello, everyone out there. This is Kurt Gallagher. I'm the Executive Director of HBMA. Thank you for joining us for HBMA Live this week. This week, we have another guest. We're doing a member spotlight this week. We have Greg Wehrman, who's the owner of Wehrman Healthcare Management Solutions with us. How are you doing, Greg? Good morning.
Good morning, Kurt. I'm very good, thank you.
Well, thanks for joining us. We've got an East Coast, West Coast, broadcast today. So I appreciate you joining us a little earlier in your day.
Sure.
So, Greg, you want to tell our viewers a little bit about you? What is your company all about? What's your journey been in terms of getting involved in the RCM industry?
Sure. Well, my original company was a charter member of the organization before it was even the HBMA, and a couple incarnations before HBMA.
Oh wow! So you're way back.
I've been involved for a long time.
Yeah.
Back when I started, everything was on paper. So I've seen lots of changes and lots of growth in the industry, some necessarily good, some probably bad.
Mm-hmm.
I first got into the industry. I was simply a college student and living at home still, and had quit my job. And at some point, my parents were sort of, come on, what are you going to do with your life? And I started to work for a gentleman who owned the company, who was a friend of my mom's, and the business was out of his home. And after a few years of working for him, he hit a midlife crisis and told me, just let you know, I might be selling the business and you may not have a job. A few weeks went by, and a couple of the doctors were sort of panicked because at that time I was sort of running the company. And I think we did billing for 5 or 6 doctors. It was pretty small. And one of the doctors approached me saying, if you'd like to buy it, I'll back you.
Wow.
And one thing led to another. I was 23 years old and bought the company, and ever since then have just run with it. And I've had some different versions of my company, but I've been in the industry now for 35 years.
Wow.
I've gone from attending HBMA events from the young punk kid to maybe not so young anymore.
Well, now you're the sage, wise member, right? Share your wisdom, which is what you're doing today.
Right. Theoretically, at least.
Medically. Well, there you go.
So.
And those early doctors you're working with, were they specialized in a certain area of care?
Yeah, from the get-go, I've specialized in psychiatry and mental health.
Okay.
Over the years, I have expanded that. I've gotten referrals from neurology is so interconnected with psychiatry. And I've done some infectious disease and infusion billing. And I was at an HBMA event many years ago, and a couple of the consultants they preached a concept that you can't be an expert in everything.
Mm-hmm.
And I've always taken that to heart. Find a few specialties within healthcare in the RCM business and become an extreme expert at that and do that very, very well. And that model may not work for everyone in the HBMA. I think it depends on how big you want to do.
Mm-hmm.
I know some of the larger companies in the HBMA, you sort of create departments by specialty or necessarily by state. So, what's worked for me is sticking with the psychiatry and mental health and continually ask for referrals from existing clients. Over the years, well over 90% of my business has been referrals from existing clients.
Oh, wow. That's great. It's a powerful testimonial about the service you're providing.
Sure. I'm a firm believer that anything with any industry that you're in, it really boils down to customer service. If you're in an industry where you make something, another company can make that. Another company can do medical billing. Can you do it better as far as customer service? All my clients have my cell phone. Sometimes that's challenging. And one of the biggest things over the years that I hear is, wow, my previous billing service, it took forever to get a hold of them. And so my attitude is, if I'm not reachable to my client in a very short period, then I'm not doing my job. Someone else can do medical billing. It's can I do it with a better level of expertise and explain it. Doctors didn't go to school to understand medical billing. That's why they have me, just as much as
Right.
I didn't go to school to prescribe medicine.
Exactly. No, that's a great point. And it is all about, providing that service, working with HBMA too. And, it's about HBMA providing service to our members and making sure that we're being of value and of support. So I totally get that. And I think that really healthy attitude that you've got. And so, as you were talking, and I know you've been involved in the Commercial Payer Relations Committee
Sure.
over the years as well. And last week we had the leaders of that committee on. We had Val and Sue. But as you were talking about, the challenges of getting a hold of someone, within maybe a billing company, I thought about, there's also similar challenges we hear from members reaching the payers. And I know that's something that the CPR committee has sort of talked about and engaged with different commercial payers on that issue. Have you seen any sort of progress in the area? I know that we hadn't initially talked about discussing the CPR committee, but you sort of triggered that thought in terms of
Sure.
one of the challenges members have had.
Sure. Well, I've been involved with the CPR for well over 10 years now. Many people, if you've been involved in the education of HBMA and a member, I'm a former chair and vice chair of the committee, and I still remain a member. I'm the liaison between CPR and GR, the Government Relations Committee. And that was sort of developed over time because one of the big changes in the industry is that line has blurred. It used to be that government relations was Medicare and CMS and the Federal Register and working with government. But as we all know now, Medicare Advantage plans, Medi-Cal HMO plans are all run by private companies. And so that was sort of developed over the last couple of years to make sure the two committees were not working on redundant features and how we could complement each other. And I think it's helped both committees understand both sides of that equation. And with CPR, to your point and question about communication, everything, look what happened with, the HBMA conference last year. It went virtual because of the pandemic. Our technology within healthcare and just in the world in general is changing. Insurance companies, just as we as RCM companies, my biggest overhead is directly related to employee care. So if I can automate something, and insurance companies have realized that same issue. And so, even 5 years ago, 10 years ago, if I had a problem, on a claim, one of my staff picked up the phone and you talked to someone.
Right.
Just as we are trying to automate and go to self-service, insurance companies are doing that too. And it can be very frustrating. So what we've seen with the CPR committee is instead of picking up that phone, you're jumping on a web portal. There's a lot of portals out there. You have the Optum Link, you have Availity, you have Navinet, you have, Medicare has their own portals. Every insurance company has a portal. Managing those portals and passwords just in and of itself can be difficult. And the CPR has really worked with the four major carriers we have of saying, wait a minute, you're not really allowing a billing service. A billing service might access, 10, 15, 100, 200 tax IDs. And there needs to be a way for a billing service not to need 200 logins for one portal. And most of the payers have been very receptive and realized that, as a billing service, one of my staff members has one login, and then that login can be linked to multiple tax IDs. And really, the CPR has been responsible for some of that, and many of the membership may not know because we do it behind the scenes, and just try and bring some level of understanding of having that. And recently, the CPR has expanded. Most of our in the past, our contacts at the various insurance companies have been either, some combination of EDI or provider relations. Different payers call them different things. And we've really had a push in the last year and a half to expand that into contracting and credentialing. That's been a pain point.
Yeah.
And that's another area where all the payers are really gradually, some are more early adopters, as everyone is in life. You have early adopters and late adopters of taking that paper process and making it electronic.
Mm-hmm.
And so I know there's been I've had a staff member work with a couple of the payers. Val Patel has, there's other CPR committee members who have actually done some beta projects on streamlining that process. And that's another thing that the membership may not know that the committee does.
Mm-hmm.
But hopefully the end result is it makes it easier to get our clients contracted. And maybe in some regards, we don't take the time to toot our own horn on the CPR committee. And that's okay. It's not about the glory. It's about, there's also a little bit of self-serving in there, in that we realize if we can help all members of HBMA, we're also helping ourselves understand and maneuver that process. And I think that's come a long way. And the payers, amazingly, are very receptive to feedback. And that's something that 10 years ago, the CPR committee really struggled with. And now the payers really lean on us to say, does this work? Does this make sense? A certain process on their web portal. And definitely, just as, one time in the industry, the norm was paper claims.
Right.
We all know everything that we can do electronic, we try and do electronic. The same thing is going to be with follow-up, whether that's follow-up on claims or follow-up with contracting and credentialing. That's all going to self-service on portals. I think the point we're at now is also trying to work with each payer, saying this is all great and it makes a lot of sense. But at some point, it's still needed where you can pick up the phone and talk through a problem with someone. My own company with a couple of the payers, most of the time it works fine. But then for whatever reason, you get a certain contract for a client that's stuck. And no one can figure it out. There still needs to be times where you pick up the phone and have that person-to-person interaction.
Mm-hmm.
And some of the payers are starting to realize that, you maybe can't do 100% automation.
Well, it's interesting. It's also, I think, a powerful testimonial of the impact the committee has had and HBMA has had. I said sometimes the committee and maybe HBMA doesn't toot its own horn, and it's important that we do communicate these successes because they don't just happen. They take a lot of effort. They also take, as you alluded to, years of developing that relationship with the payers, and it's just the time I've been on, just seeing the evolution of that relationship in the last few years has been something I've been happy to see, and it's the work that you've done and Val Patel and Sue Bailey and other members of the committee over the years who've developed and fostered those relationships. So. Yeah, we need to make sure that members are aware, because without HBMA, that progress might not happen at all, or certainly be impeded.
Sure.
And then, I know you wanted to also talk a little bit about telemedicine. Certainly within behavioral health, it seems like there's been a significant shift over the past year and a half towards that. And then there's a lot of uncertainty about the future, about where we go in terms of that as an option for providing care.
Yeah, something you and I talked about when we were discussing, what should this session be about. I mentioned telemedicine, and I wanted to come at it from a different angle.
Mm-hmm.
The Government Relations Committee is keeping on top of what's happening in Washington, D.C. And, if you think back, look at the last 18 months with the pandemic, politics aside, it's really drastically changed our industry. Mm-hmm. It's changed the doctors and how they render care. In April and May of last year, I think every HBMA member was the sudden shift of how, helping. I helped a lot of my clients, I had one that was an 80-year-old psychiatrist.
Wow.
And I helped him transition to telemedicine. He's he wasn't very techy, and now
Mm-hmm.
he's been forced to. For the RCM companies, we've been forced to. How do you get the claim billed?
Mm-hmm.
Um, and I think every member to some degree had to do that. And Medicare's great because they're, as far as a payer, they come out with very easy to read published guidelines. Many of the private payers came out with regional guidelines, national guidelines, and you had smaller payers and medical groups that just really didn't know what they were doing. I know still to this day, how I bill a telemedicine claim varies according to payer,
Right.
because the guidelines have not been consistent. Um, so, pre-pandemic, telemedicine was sort of done either with Medicare, very rural areas where
Mm-hmm.
the regulations allowed, or it was sort of dominated by these big national companies, especially in behavioral health. There's about 4 or 5 companies. And if you pay attention to TV or radio, they advertised. And that's changed now. Pretty much every psychiatrist in the nation does some level of telemedicine. There was an HBMA news blast. How the HBMA has been great with Matt Ryder and putting out those. I still think it's 2 or 3 times a week summarizing.
Yeah.
Well, there was one of those studies that was featured, and I forget exactly what it was a few weeks ago, that I found very interesting. And it was someone that had done a study where pre-pandemic, 18% of America preferred telemedicine. And the study concluded that, it was done a couple months ago, it was 38%. And that's very significant
Yeah.
because that's a much higher market penetration. So I think, post-pandemic, telemedicine is here to stay. We just don't know what the rules are going to be. And,
Absolutely.
there's been some talk, in Washington about changing those rules. At some point, the pandemic will, the public health emergency, the PHE, will be declared over. When it's over, a lot of the national payers have said these are our rules on telemedicine as long as the PHE is in force. What none of us really know is what are those rules going to look like? And one of the things that I've really thought about, and I try and read every blog. I've been to a couple seminars, one that was paid, one that was free about
Mm-hmm.
telemedicine. And I honestly think some of them are ripping people off by charging because they're saying stuff that we already know. So I was trying to come at it and being forward thinking, what's it going to look like for a billing service?
Right.
And I think very conceivably, although we don't know for sure, I think all of us are going to be dealt with. There's going to be multiple scenarios still,
Mm-hmm.
For instance, I'm in California. So one of the big payers is Anthem Blue Cross of California. Well, Anthem Blue Cross of California has a wide array of coverages and plans they offer. Some are regulated by the state of California. Some are self-insured, so they're regulated by ERISA law. Some are Medicare Advantage plans, so they're regulated by, federal regulation. In San Diego, we have a huge amount of TRICARE.
Mm-hmm.
So we may have in the future where how a doctor practices telemedicine varies by the patient's regulatory agency for their particular insurance plan. And
Right.
so we may end up with a very divergent, the state of California could do something very different than the state of New Jersey, than the state of New York, than the state of Texas. California actually had a pretty robust telemedicine law on the books, and it's been on the books for years. And it in a nutshell says a telemedicine visit has to be covered and paid the same as if it was in person. Some states had telemedicine laws, others didn't. Others had where the payment could be reduced. There's been some question, will Medicare allow it, but will they use this as an opportunity to save money? And says there's a reduction for, telemedicine. These are all things we need to consider. And right now, some payers use a GT modifier, some use a 95. To me, that's always shown the lack of understanding of coding by payers, because if you really dive into it, the GT modifier is a HCPCS modifier, and the 95 is a CPT modifier.
Mm-hmm.
So technically, the GT should only be used on HCPCS codes, and the 95 should be used on CPT codes. But most payers, I find, recognize one or the other, or even both. So I think
like there's some education that's needed there.
Yeah, but again, do you want to fight the payers and try and educate them, or just do what they need to do to get the claim paid? Where do you want to spend your effort?
Well, and that's maybe where the CPR committee comes in, or maybe GR committee. It's something that maybe we try to address longer term, while shorter term, you are getting paid. You keep your lights on and pay your employees, right?
Right, exactly. So some of the things I've sort of looked at, that a lot of doctors that I've had to educate the doctors on is technically the service is rendered where the patient lives, not where the doctor is. Some states have reciprocities, especially on the East Coast with some of the smaller states. So if I'm a doctor in California and my patient moves to Arizona, do I have a license in California? Does my malpractice cover Arizona?
Arizona, right.
These are fine point questions that I think perhaps could be addressed on a national level of, do we change how telemedicine is regulated? Is that the first step in changing licensure for doctors to be able to be across multiple states? Well, I think states are going to fight that, because I think it comes down to, if I have to be licensed in Arizona and California, that's an income stream.
Right.
And so does your malpractice, is it practical if I have just 2 or 3 patients in another state? Is my malpractice going to cover that state? Do I need a separate policy?
Yeah.
I think in the long run, I think right now, even Zoom, the non-HIPAA security compliant Zoom is okay. I would expect that to change and have to secure standards. I think too, even in our industry, the amount of telemedicine you have, obviously in psychiatry and behavioral health, is going to be higher than in other specialties that are more invasive.
Right. Well, you obviously pointed out a number of the complexities of the issue, and you mentioned, at least for California, it's based upon you said the residence of the patient. What if the patient's on travel?
Well, that's always my understanding. That's been always okay, especially in psychiatry. The analogy I've always heard is a baseball team. If the San Diego Padres are playing Bills, Washington Nationals, and a player needs an anti-inflammatory, the San Diego doctor is still allowed to prescribe and see the patient. Okay. It's because you don't want a crisis situation in mental health. If someone's in crisis and they happen to be away on travel, you're still allowed to do that. But as soon as they establish residency in another state, that can be a dilemma. And yet I've talked to some clients. Okay, you have a psychiatric patient who moves from one state to another and then suddenly has a crisis. Could there also be some legal ramifications by not seeing that patient as far as patient abandonment?
That's a great question too.
These are all legal questions that I think, as we move forward with telemedicine, for us as RCM companies years ago, there was a time where I had my billing program was on a server in my office. Mm-hmm. Long ago, it moved to the cloud. I view the technology of telemedicine now as sort of an analogous change. Yeah. Even right now in California, I have doctors that their office, quote unquote, is here in San Diego, but they're seeing patients in San Francisco.
Well, at least they're all in the same state. But yeah, I think it's an interesting point. But the other thing to consider, especially in an area like DC, or let's say the tri-state area up in New York, a patient may move to a different state and not notify the doctor.
Right. Or even work in one state and live in another.
Yep. But, the cell phone number that the doctor uses for that telemedicine visit, was likely to be the same.
Sure.
So that adds another layer of complexity. And, then is that something that your physicians, the doctors you work with now suddenly to do that check of not only is this your insurance, is it still valid, but is this still your residence that you live at now compared to 2 weeks ago?
Yeah, these are all thought-provoking stuff that I'm not sure if politicians in Washington or politicians in any one state or group of states really understands to enough degree, um, to where the law that we end up with, are we going to react to the law? That's always been tough for the HBMA, is to have the financial means to really do a lot of lobbying at a local level. I think the HBMA does a great job at the Washington, D.C. level. But
Right.
as RCM companies, so much as we deal with is at the state level. And I think that's going to really rely on each individual member to maybe do a little lobbying for themselves at the state level.
Yeah, the state level lobbying, it definitely gets complicated.
Sure.
And the lobbying rules in each state too vary.
Yeah.
So Greg, where do you think things are going though? Do you want to share what you think might happen in the next few years? I mean, you don't have the proverbial crystal ball, but do you feel
Right.
comfortable sharing what you think might happen, or is it just there's just too much uncertainty?
Well, there's a ton of uncertainty. I think the biggest thing is, for me, I'll rely on a lot of the HBMA, but that's going to be more the national level. There's listservs out there. I think the big thing is we have to be flexible. Something I tell my staff, I tell clients, I've brought it up to other HBMA members.
Mm-hmm.
10 years ago, if I had, say, a friend ask me, I'd say, what do you do? And, oh, I'm a medical biller. I'm a revenue cycle management company. And the common person many people don't understand that.
No, they
But
wouldn't.
if I had to sum up my job now, in just very simple layman's terms, I'm a problem solver. There's something that happens that is an obstacle to get a claim paid, and I find a workaround somehow.
Mm-hmm.
Whether that's adjusting with not making phone calls to a certain insurance company and going on the portal. So I think it's you have to stay current, but you have to remain flexible. You have to constantly, as an RCM company, be reviewing your policies and procedures.
Right.
How I do stuff. I don't. 25 years ago, everything was on paper. I hope no RCM company is still sending everything on paper. And with telemedicine, we're going to be in a big change. And we may see it change and then be refined and change a little more and change a little more through that feedback between what works and what doesn't.
Right. Well, we've had to be very flexible over the last 15 months, and
for sure
we'll have to be this equally flexible moving forward. Different challenges, but still adapting to changing circumstances and a changing world. So
yeah, and I think that brings more value to HBMA. The biggest, Kurt, I've known you for a while now, and you've heard me say this. I want to say this to everyone listening. The biggest value of the HBMA is networking.
Yeah.
I've learned, as much or more when I go to a conference, maybe after hours sitting at the bar and talking with a group of members over a beer and saying, someone goes, I'm having such problem with X. And you have 5 or 6 other people that are having the same problem. First of all, you get this sense that I'm not in it alone.
Right.
I'm not the only one having a problem. But then you have these, oh, this is how I fixed it. This is how I fixed it. And you get these ideas. And I think, something like the HBMA, you get out of it as much as you put into it. So I know Val and Sue last week said, join a committee. Other people have said it,
Yep.
If anything, you get to know other people. Where my company has been a charter member, I literally have in the past, when I have a problem or maybe I get a doctor of a new specialty, there's probably 30, 40 phone numbers from members or emails that I can pick up the phone and call. And
Wow.
they'll drop what they're doing to help me. And I've done the same for other people.
That's great.
Form your own little networking group. I know there's a group of us involved in the HBMA that specifically do psych billing.
Mm-hmm.
And occasionally we'll send an email to a group of, there's about 5 or 6 of us that have just sort of become friends over the years. And sometimes it's a very specific problem. And within the hour, you get 2 or 3 emails back of, maybe look at this regulatory, or this is how I solved it, or I'm having the same problem. Let me know if you fix it,
Right. Well, that's something I noticed when I came on board with HBMA. I worked for a number of organizations, but I don't think any were as vibrant when it comes to that sharing and that sort of sense of community that HBMA has. It really is something special. So.
Yeah, it really has been. I mean, from the get-go, since I've been a member of the HBMA, a lot of times in trade associations, you get this adversarial sort of attitude that if I share my secret, you're my competitor. And I think the thing that's very unique about us is there's enough healthcare business around there for all of us. Yep. And no one's been afraid to share. I think, hardly ever have I ever come across that in all my years of working with the HBMA. I think that generosity, and I'm just in life, my own philosophy is, I believe in karma. If I reach out and take a little bit of time and help another HBMA member, that probably comes back to me 2, 3, 4, 10-fold.
Absolutely. I think that's a really healthy attitude. And it's perfect for someone who specializes in behavioral mental health, Greg. So well adjusted. Well, Greg, I think you're planning to join us in Dallas in September, right? So
I'm looking forward to it. I'm a person, I missed last year. I like the face-to-face interaction, and I'll be there. I'm looking forward to seeing many colleagues and people I consider, personal friends over the years. And I'm very excited to be there.
I'm looking forward to it as well. Get back to be with the members. Like you said, it's about customer service, or in my case, member service. So that's what it's about, and get so much energy being back with everybody. So Greg, thank you so much for joining us and sharing your perspective. And I think it was an interesting conversation about telehealth and some of the other just changes and challenges in the industry. But love to have you back again in the future. And for now, wish you a good day because it's early for you. So
thank you. Yes, I still have the day for me, and it's been my pleasure. This is just another way to share.
Absolutely. Take care, Greg. Bye-bye.
Thank you, Kurt. Goodbye, everyone. Have a great day.
See you, everybody. Take care. And see you next week, hopefully. Same time, Thursday.